Welcome. Obtaining the 5 views for Pocus Cardiac. This module is best viewed on a laptop or desktop. Let's get started. This should take about 15 minutes to complete. More information can be found from this JACE article. You may download this article from NUS Media web platform. We first look at the scanning planes of the heart. Imaging of the heart is described in 3 planes. These are the long axis plane, short axis plane and apical plane. The parasternal long axis view corresponds to the long axis plane of the heart, whilst the short axis plane is imaged with the parasternal short axis view. The apical plane is seen in the A4C view. The windows used to image the heart are described here. These are the suprasternal notch, right parasternal, right apical and subcostal. The apical and parasternal windows are also obtained from the left side of the chest. These windows are used when a comprehensive transthoracic echo is performed. For point-of-care cardiac scans, we normally only use 3 of these windows to image the heart. These are the left parasternal window, the apical window, and the subcostal window. The long axis and short axis plane of the heart is imaged from the parasternal window, whilst the apical plane is imaged from the apical window. The subcostal window allows imaging of the subcostal 4-chamber and IVC views. We next describe transducer manipulations. Transducer movements are important in obtaining good quality images that can be interpreted. The movements are described using the terms tilt, sweep, rotate, slide, rock, and angle. We will take a closer look at these transducer movements next. The term sweep refers to multiple transducer movements recorded into a long video clip to show multiple anatomical structures. An example of a sweep would be recording the tilt planes from posterior to anterior in the apical window in one long clip. Here we see the tilt maneuver. The term tilt refers to a movement in which the transducer is fixed in position. The face of the transducer is moved to demonstrate other image planes in the same axis. The term rotate refers to keeping the transducer in a stationary position but turning the index marker to a new position. An example would be moving from the parasternal long axis to parasternal short axis view. The term slide refers to moving the transducer over the patient's skin to a new position. This is demonstrated in the image above. The terms rock and angle refer to smaller movements used to optimize an image. Rock refers to an action of moving the transducer, staying in the same imaging plane, toward or away from the transducer orientation marker to center a structure or extend the field of view. Rock differs from tilt, in that the rock motion stays in the same imaging plane, whereas the tilt motion refers to motion in the same axis but different imaging planes. Angle refers to a motion in which the image is optimized by keeping the transducer in the same position, and directing the sound beam toward a structure of interest. Let's now go through the 5 views in more detail. The figure summarizes the views that are used for Pocus Cardiac. We first obtain the parasternal long axis view followed by the parasternal short axis view. The apical 4-chamber view is then obtained followed by the subcostal 4-chamber and IVC view. The parasternal long axis view is obtained with the transducer in the left parasternal 3rd to 4th intercostal space. The marker on the probe should face the patient's right shoulder, or at the 9 to 10 o'clock position. Use this view to assess the LA, LV, mitral and aortic valves, ascending aorta, and pericardial space. The pleural space and descending aorta can be imaged by increasing the depth. The left ventricle should appear perpendicular to the ultrasound beam. The apex is usually not visualized in the PLAX view. In this view, 2 of the 3 aortic valve leaflets can be seen in the long axis. Zoom can be applied to the aortic valve and mitral valve to visualize the valve in detail. Color Doppler can be used to interrogate the mitral and aortic valves for evidence of regurgitation. Here we have color Doppler placed over the aortic valve. There is no regurgitation, and the valve leaflets are seen to open well. The leaflets are thin and mobile with no evidence of calcification. Interrogation of the mitral valve with color Doppler can be done next. This valve is normal, with no evidence of mitral regurgitation. The leaflets coped well at the level of the mitral annulus and there is no evidence of stenosis. In the PLAX view, we should also assess the size of the LA, ascending aorta, and RVOT. As a general rule, the sizes of these 3 chambers should be approximately identical. Measurements of LV internal diameter in diastole and systole, and LV wall thickness can be made here as well. Fractional shortening can then be calculated. Placement of the M-mode cursor across the tips of the anterior mitral valve leaflets allows for EPSS to be determined. This is a useful marker of LVF. We can now look at the parasternal short axis view. This view is obtained by rotation of the transducer in a clockwise direction from the parasternal long axis view. The transducer marker should now face the patient's left shoulder. Sliding or tilting of the transducer allows for different planes of the heart to be imaged in the short axis view. The LV can be imaged at the apex, mid-papillary, and mitral valve level. Moving closer to the sternal edge and higher up the chest allows for the aortic valve to be imaged in short axis. We are imaging the LV in its short axis at the level of the mitral valve here. The opening of the mitral valve can be seen as a fish mouth in the middle of the LV cavity. The basal segments of the LV are visualized. Slight tilting of the probe inferiorly towards the apex of the LV allows for the mid-papillary segments of the LV cavity to be imaged. The anterolateral and posteromedial papillary muscles are seen. The inferior, anterior, lateral and septal walls of the LV are visualized. This view is useful for assessment of global LV systolic function and regional wall motion abnormalities. Tilting of the transducer superiorly and towards the left sternal border allows for the aortic valve to be visualized in its short axis. The RA, RV, and pulmonary outflow tract can also be seen here. This figure shows the images that are obtained when scanning the heart in the short axis at the different levels as previously described. We can now move to the apical 4-chamber view. The apical position is usually found on the left side of the chest near the point of maximal impulse, aligned near the mid-axillary line. A good starting point is the 5th intercostal space. In general, when imaging in the apical window in a normal heart, the long axis from the base of the left atrium to the apex of the left ventricle should consist of about 2/3 left ventricle and 1/3 left atrium. This is a helpful subjective guide to know that the left ventricle is not being foreshortened. In addition, the left ventricle should taper to an ellipsoid shape at the apex. If the ventricle is foreshortened, the apex will appear rounded. The lateral and septal LV walls are seen. The RV and LV can be assessed for global function and for chamber size. The mitral and tricuspid valve can also be interrogated with color Doppler. Tricuspid annular plane systolic excursion or TAPSE measurement can be done in the apical 4-chamber view with M mode. Similarly, mitral valve annular excursion or MAPSE can also be assessed. This M mode shows TAPSE. Pulsed wave Doppler can be used to determine mitral and tricuspid inflow velocities. EA ratio is shown here, which is used to determine grades of LV diastolic dysfunction. The subcostal window is next. This window is used to assess the heart, pericardium, RV free wall thickness, and great vessels located in the abdomen, IVC and SVC, hepatic veins, and abdominal aorta. It can be very useful for imaging the heart when the images are suboptimal from the parasternal window. The SC view is obtained with the patient laying supine with abdominal muscles relaxed. This is the subcostal 4-chamber view. The transducer is placed in the subxiphoid position, with the marker facing left. The transducer should be angled towards the patient's left shoulder. From this image, the right atrium, TV, left atrium, MV, left ventricle, interatrial septum, and interventricular septum can be examined. Finally, we look at the inferior vena cava. The IVC diameter is measured from the SC long axis view, with the patient in the supine position. This measurement should be made 1 to 2 cm proximal to the junction of the IVC and right atrium. The IVC should be measured at its maximal diameter in expiration and inspiration. If central venous pressure is normal, the diameter of the IVC typically collapses 50% of its expiration diameter. We can end the Pocus cardiac study here.